I'm Dr. Lindsay Kilburn. I'm one of the neuro-oncologists here at Children's National in DC. And I've been a clinical trialist with a focus on developing new therapies for children with gliomas in general and specifically with DIPG since I started my career even as a fellow. So I'm just gonna, obviously the focus today is to talk a little bit about a new trial that we're really excited about opening in collaboration with the team with Sonalisense and mention a little bit about some other studies that may be coming down the pike that are also using low intensity focused ultrasound, which we are excited about, kind of a novel approach in children that are that with DIPG to kind of think about overcoming some of the barriers that we've had in the past in terms of therapy. It's not wanting to. Okay, so, I think unfortunately this group is well versed in understanding the diagnosis of DIPG and recognizing that, we have far too many children in the US that are diagnosed with this disease. It remains one of our most challenging diagnoses, and there are so many people across the world trying to develop novel and new approaches, because the therapies that we have to date just are inadequate. And unfortunately remain inadequate on the clinical side. I think it is a really hopeful time in caring for children with DIPG because so much tremendous research and advancements have been made in our understanding of the disease itself, but we're still really working to translate these into clinical treatments that really show clear improvements. I think we have seen some small incremental improvements in our therapies over time, but we really are hoping for that true leap where we get to really more curative therapies for children with DIPG. And I think most of you have heard that some of the challenges that we faced are kind of getting novel therapies into the brainstem, getting them to the tumor cells. Years ago, we didn't have a good enough understanding of the difference of DIPG as compared to other gliomas. And I think we've made tremendous progress there, but still a lot of work to be done in terms of translating some of those advances into actual therapies that can be effective for children, that can get into the tumor cells. And so focused ultrasound is a technology that's been more recently developed that I think there's a lot of excitement about for potential, both in terms of the sonodynamic therapy, which we'll talk about, as well as the potential for its role in kind of blood-brain barrier opening and potential combination therapies that might be coming down the pike in that avenue. So I'll focus today on a study that we're excited about of Sonalisense, or in collaboration with Sonalisense, which is looking at it's a dose escalation. You can see the kind of title there, kind of looking at this combination therapy of both a prodrug and the focused ultrasound to kind of to activate that and lead hopefully to cell death. And so there's a lot of kind of more details. I'm not going to mention all of those, but basically when we think about sonodynamic therapy, we're thinking about the combination of kind of this non-invasive combination therapy utilizing a drug, which is a prodrug, so the Sonala 001, and then the device, which is the Xplade 4000 system, which allows us to deliver kind of non-heating focused ultrasound to then activate the metabolite of the drug. And so what we're looking at is the prodrug, which of ALA, and then that is activated into, or is the metabolite of that is potentially activated either by light or by the focused ultrasound into and to lead to cell death. And so there's a little bit of kind of detail here. We know already one of our challenges with many of the drugs that we've utilized in treating children with DIPG is that the difficulty of getting them to cross the blood-brain barrier. We know that ALA readily crosses the blood-brain barrier. An oral form of that has been used and FDA approved for surgical resection of glioma. And we have done further research. One of our collaborators through Children's National in Zurich has done some additional work to confirm that given some differences between adult glioma cells and pediatric gliomas and DIPG, that the DIPG cells also take up the ALA, and we'll look at a couple slides later that kind of shows a little bit of that experience, which has made us even more excited about this potential therapy. And this is just kind of a picture of the MR guided focused ultrasound. So it combines the ability to kind of look at where the ultrasound is being focused and do real-time imaging utilizing an MRI, so that you can kind of monitor the treatment in real time as it's being performed. And so we do this in collaboration with our neurosurgeons. High frequency focused ultrasound has been used for some time in adults, and very recently has been used in some pediatric brain tumor cases. But so there's longer standing experience with the more high intensity focused ultrasound, primarily in adult settings, but a move that into pediatrics. And then the low intensity focused ultrasound really has become of more interest for its kind of applications in some of these potential tumor therapies. This is just some of the laboratory evidence. Anytime we're moving a new treatment into children, we want to make sure that there's been some good data, some good experiments done in the laboratory to support the potential effectiveness in models that make sense. And so this is just an example where multiple photodynamic therapy treatments were able to lead to complete regression of a tumor model, and as well as 100% survival in that model. So we always take these information with a grain of salt. We unfortunately have been more successful at curing DIPG in mice than in children, but it's still an important first step to make sure that we think that there's the potential for an effective therapy. And I think this is really particularly exciting preliminary data. And so, the other thing we think about as we move treatments into children is, what experience we may have in adults that might help guide us. Sometimes that is misleading in terms of effectiveness, but some things can be translated well from adults to children, and certainly having some at least experience and safety information and information in humans is exciting additional data when we think about kind of opening a study in children. And so this is some information from a study using the sonar dynamic therapy in adults with high-grade glioma through the Ivy Brain Tumor Center, where they've treated 8 patients with recurrent high-grade gliomas outside of the brainstem. But they did really exciting work to try to understand kind of the toxicity of the therapy and the effectiveness of the therapy by looking at areas of the tumor that were treated with the focused ultrasound, as opposed to areas of the tumor that did not receive focused ultrasound, and saw, effective kind of induction of cell death and apoptosis, another form of causing cells to die in those areas that were treated with the ALA and the focused ultrasound together. So further kind of exciting experience in patients to make us interested in moving this type of approach into children. And this is a little bit of the work that was done to support to confirm that while there was good evaluations in the laboratory to show that this was potentially effective in gliomas in more adult type cell lines, that we confirmed that was also the case specifically in DIPG cell lines as well. And in fact, we actually saw that the ALA actually accumulated at a very significant rate and in high concentrations in those DIPG cell lines, which further supports kind of moving this forward as a clinical trial. So, anytime we're thinking about a first study of a novel therapy in children, we obviously first are thinking about kind of being cautious and doing that in the safest way possible. We want to think about an effective treatment, but also evaluate it in a stepwise way, such that we can ensure the safety and that we're, that we're not, missing anything new as we move this into a new area of the brain and obviously into children. And so, the primary objectives of the study are looking at the safety and the tolerability. Obviously, we're particularly as a neuro-oncologist, I'm of course interested in the effectiveness as well. And so we're watching for that as well. But we also we do want to be cautious as we start. This is a new area of using this type of focused ultrasound in the brainstem. We know that that's a very delicate area of the brain. It's why we're limited in terms of surgical resection and other therapies. And so we're starting with treatment to only half of the tumor in the pons as the initial treatment in the first patient, and then expanding that to then cover the other half of the tumor in a subsequent treatment. And as long as that is well tolerated, then we'll go to treating the tumor more completely, but also looking at different intensities or doses of both the drug as well as the energy, and escalating that. In general, we think in oncology that more is better, although that's not always the case with these types of more novel approaches, but we do want to evaluate some of the different doses to try to determine what we think is the best, the safest, and the most effective dosing. And then, so because of kind of looking at those different dose levels, approximately 18 to 24 children will be potentially enrolled in this study across 3 centers in the United States. We are hopeful to have this open very, very soon, and with plans to kind of further expand at University of California. And of course, the Ivy Brain Tumor Center has been working on the adult study, and also collaborating with the pediatric center there. And this just, again, mentions a little bit about what I kind of mentioned in terms of, we're thinking about this therapy in children with DIPG that's recently diagnosed, that have completed kind of what we consider generally to be standard radiation as a first step, but prior to that tumor potentially growing again at some point in the future, thinking, that because this is a new approach, we want to be utilizing it at a time that often we see that the tumor is a little bit more stable, and then thinking about how to expand that therapy beyond there once we've established kind of the gotten through these first portions of the study. I have some more detail. I have a couple slides that have the very specific details of kind of some of those criteria, but really looking at standard requirements to enter a clinical trial that we generally use to make sure we feel like it's safe to be giving kind of a novel combination treatment. And so those are pretty common across most of the clinical trials that we have for children with DIPG. And I think those were the main slides. We also, as I mentioned early on, I think this is our first step of utilizing focused ultrasound in the development of trials for children with DIPG. We are also working on developing 2 additional studies, which will utilize focused ultrasound in combination, utilizing it more not to activate the therapy for this, as this study does for sonodynamic therapy, but focusing more on that potential to open up the blood-brain barrier. And there's been a lot of work to suggest that when you use focused ultrasound with microbubbles, which are utilized in cardiac catheterization, some other procedures, and have been also, are very safe, that allows for some opening of the blood-brain barrier. And so in a kind of a different approach, we're hopeful that that might allow us to give focused ultrasound with those microbubbles, with medications, which we might be excited about based on what we've learned about them in the laboratory, but we know we've had difficulty getting them across the blood-brain barrier. And so there's a couple a couple different medications that we're looking at evaluating. Hopefully in the next 6 to 12 months, those studies may also be opening here, potentially at other centers. I'll pause there. Sorry, I went through that relatively quickly, but if there's questions or comments from the Sonalisans team as well. Maybe stop sharing for a second. I can get back. And questions or thoughts, if they're hopeful, if that wasn't exactly what you were hoping for in terms of that, I'm happy to answer any questions or provide additional information as well.
Why are you, sorry, go ahead.
No, I'm sorry. I just wanted to know, you said the ALA is not, can you hear me? I'm sorry. ALA is not taken up by normal cells, is that right? Yeah.
No, it's preferentially taken up by glioma cells, and that's kind of how it's actually been. An oral form of it's been used for some time, and it's been studied as more of kind of like a tumor paint type idea where it can help identify the glioma cells, and so and it does also seem to be kind of preferentially accumulate in DIPG cells as well.
And I'm just curious. I know you mentioned you treated about 8 patients, adult patients with glioma before surgery, and then the surgeon found the part of glioma which was treated had a tremendous response. Just curious, have you treated anyone like off protocol therapeutically? Do you know of anyone that was
Any children with DIPG, you mean,
or any children, adult patient with glioma? I'm just curious.
No, not that work has been done at the adult center. We're exclusively children's hospital, so that kind of part of the study was done by another team. So I personally haven't treated treated those patients.
I see. And you mentioned this trial is open now, or
not quite open, although we're very close. We've been working very hard to get everything in place to open it soon. And I think the one point that I didn't mention is because of being, because this really is a very novel approach, we are being cautious and slow with evaluating, one child kind of initially. And I mentioned that we're also treating kind of first half of the tumor and then the other half of the tumor, just to make sure that there's not any unexpected side effects primarily, I think, from a neurologic perspective. And so because of that kind of staggered treatment, we will be treating one child, and that process will take about 2 months. And so, before then subsequently enrolling kind of the next child. So the beginning stages of the trial will be a little bit slow, but will, I think for good reason to be, I know it's a balance between wanting to advance things and understand things as quickly as possible, but also wanting to make sure that we're doing things as safely as possible, and ensuring that if we need to change anything about the approach, that we can do that, as needed. But
thank you for the presentation. Why are you? Question is, so the ALA produces oxidative stress and kills the cells. Has it been used as a sole medication for DIPG?
Yeah, I should have been clear on that. So the ALA kind of is really non-toxic to the cells by itself. And the same thing with the low intensity focused ultrasound by itself, is really an intensity that is felt to be non-toxic. And so it's really the combination of the two that potentially creates the reactive oxygen species and then leads to cell death or apoptosis. And there's a fair amount of safety, information for both agents. The high intensity focused ultrasound can cause cell death, but we're talking about a much lower intensity, kind of a non-heating dose of the ultrasound which is really working kind of synergistically with the ALA.
Thank you. Now I understand. I was wondering why the combination.
Yeah.
And yeah,
Sorry.
now I can. Okay, thank you.
I meant to say that, and I clearly didn't say that clearly enough at the beginning. So thank you for your question.
Thank you.
Dr. Kilburn, I might have missed these details, but after the first half of the tumor is treated, how long before the second half of the tumor is treated?
So the second treatment will be at day 30 after the first treatment. So about a month, you know, and then for after the first child at a particular kind of dose level, the next child, the whole tumor will be treated. So it's just that first patient that has the half and half treatment, kind of, but at each level.
So if in the first child there's some growth in the part that wasn't treated, in between there, will you do anything different, or?
I mean, I think the goal will still be to treat, you know, the tumor area. So I think we're, you know, the treatment is based on kind of the MRI at that, you know, we have real time.
Oh, I see.
So I think the hope will be to really to treat that half in its present state.
Okay, so half of the pons. I was thinking half of the tumor. This makes so much more sense. Very good. And as I understand, this treatment does not make a patient ineligible for any other treatment except, is it the DIPG vaccine? Is that the only one that?
I think that's a great question. I'd have to look, you know, I think that some of our studies there are a number of studies right now which are kind of have that criteria of not having of enrolling within a certain time of either diagnosis or more often with completing therapy. So I think there are a few studies that this, you know, going on this treatment might exclude in that subset. But there are other therapies that are potentially available, and there is not an exclusion from kind of going on to a different therapy if the child is eligible, kind of once they're beyond that safety phase.
Okay.
And there, I think, and then other, you know, sometimes, you know, oncologists will work with a family to think about, you know, another option outside of a trial if something makes sense and seems appropriate, you know, in the context of that child's individual therapy.
How many weeks after ending radiotherapy can they enroll? Or can they start the treatment if they're enrolled?
So, and I'm just going to make sure that I say this right, because I was just looking at something for another patient for another study. So yeah, 4 to 16 weeks. I just wanted to make sure that I was saying that correct. Yeah. So 4 to 16 weeks after finishing the radiation is that window that you can enroll for this study.
And if somebody's interested in enrolling, how do they go about doing that?
So certainly I can put my email maybe in the chat in a minute. You can certainly just reach out to me directly and I can facilitate, depending on where they are and where we are in the study, you know, connecting to either our center or if we're in a place for the other centers, and that would be a better option.
Okay, thanks.
So it's, I'm sorry, I just want to be clear. So they're only eligible, it's like first line treatment after radiation.
Correct.
If they received some other treatment, then they won't be eligible, right?
Correct. Yes.
Mm-hmm.
I see a question. Are DMG?
Yeah, not at this, no. So this is specifically, you know, because it is kind of utilizing this focused approach, we're trying to kind of understand it in a group of patients that have, you know, a tumor in the same location. We obviously do think about, you know, now it's complicated. Some of the studies are specifically for children with DIPG, others for, you know, as we think about, you know, DMG kind of being more of a continuum. But at this point, the study is just specifically for children with DIPG. And I don't know if anyone, I know there are some of the team from Sonalisans on the line as well, if anyone had any other comments to make.
I would just like to comment, we're super excited that Children's National took this step and offered to allow children as young as you are to do it. We know there's often hesitancy or pushback for a variety of reasons, but it's really exciting that this is very non-invasive, and we are so hopeful that it will work and it will work on the very first patients, and will give just an incredible option to parents that are coming after. So thank you so much. Thank you to the entire team. I know you've worked tirelessly to bring this to the community. I know Dr. Packard and Dr. Kilburn really championed using it in DIPG, and we appreciate the investment in our children.
Yeah.
Well, thank you for all your support, Lisa.
Always, always.
Yeah.
Fingers crossed, toes crossed.
Yeah, we're really grateful for the collaboration here with the team at Sonalisans. I mean, I think that, you know, kind of that step to really make sure we looked at this in DIPG specifically, and to get, you know, to get that to our preclinical team, you know, very quickly. And, you know, I think it's been a wonderful collaboration. So, you know, I think as we more and more have learned and are trying to develop therapies for this disease, that our collaborations with our industry partners is really important. And sometimes some of those are more facile and ready to work with us quickly than others. So, you know, we're also really grateful for that. But we are excited, and Dr. Packer had hoped to be here this evening as well. But and I think there's been interest in this for a long time. And I will say Dr. Packer, you know, is a force, and we've worked hard, but he has really, you know, helped us to bring this to Children's National. And we're hopeful that I think that is one of the challenges. I would love for this to be available more broadly in more places across the country. But because the technology for the focused ultrasound is unfortunately not available everywhere yet, and hopefully it will be if we find it to be effective. Well, that'll be the next step, is to get it more places, or to figure out how to get all the children here that need to get here. But you know, I think we're excited to be able to offer that, and we'll work with families to try to help get them here, however we need to do that.
Yeah, no, thank you, Dr. Kilburn. Both you and Dr. Packer have, you know, been great to work with. And, you know, for everyone on the call, you know, this was when we first approached Dr. Packer to talk about sonodynamic therapy. His immediate reaction was, "We got to try this in the IPG." So we're really grateful to him for suggesting it.
And I'm not sure if you guys know, but with the help of Lisa, the Mark Jr. Foundation, we're working to help parents get to clinical trials. So if you have any parents who need assistance from just coordinating travel to helping fund travel, just have them reach out to us, and we'll see what we can do to assist them. And actually the Children's Brain Tumor Foundation steps in for a ton of assistance also. So thank you, Regina. So yeah, so if you guys find you have any parents who need assistance, you know, let us know.
Will do. Thank you.
I know I saw Leslie Jarrett on the call. Leslie is the chief nurse navigator at the My DIPG Navigator system, which is rolling out very soon in a couple weeks. But Leslie, I don't know if any of the other navigators are on tonight, or if you're running point.
I think they're on the phone, but I'm not sure. It says iPhone, but I think they are. And I want to say thank you to you, Dr. Kilburn. I think we've already got somebody we know that you're going to be working with, and it's so exciting to me to think that some non-invasive thing might be able to help these children and these families. So I also want to thank you, Lynette at for Mark Jr. for helping with travel, because we help navigate, but we don't help with the travel expenses. So it does take all of us working together to help these families, and our fingers and toes are crossed. So thanks, Dr. Kilburn. Appreciate it.
And thank you, Dr. Kilburn, and thank you, Leslie, too, because you're a huge help too, and you're always so kind and generous and patient. So I really do appreciate your time. So thanks.
Yeah.
Dr. Kilburn, are there other studies going on at Children's National too that you'd like to just take a minute to focus on? Am I correct that there's nothing else ultrasound wise quite yet? This
Not quite yet.
Sono Dynamic is the leader of the pack. We might not need anything else.
Right, exactly. That is certainly our hope.
Yeah.
We do have, we will, as I mentioned, have another focused ultrasound study with kind of micro bubble and a more conventional chemotherapy, doxorubicin, which hasn't, gotten into the blood-brain, doesn't cross the blood-brain barrier very well, but does seem to potentially be effective against cells. We kind of shy away from more conventional chemotherapy in treating children with DIPG. For a variety of reasons, but we do utilize it in treating gliomas in other parts of the brain and do think it's effective. One of those barriers is probably the more intact blood-brain barrier in the brainstem, and so there's some hope that being able to disrupt that may make that type of a therapy better. We also, one thing I actually meant to mention, didn't mention, is there's also a lot of interest in low intensity focused ultrasound for potentially stimulating kind of the immune response. There's obviously trials all across the country looking at CAR T cells and other T cells, and we have our REMIND study looking at tumor antigen associated T cell therapy, which is not solely for children with DIPG, but there is an arm of that study for children with DIPG. Again, kind of in that same post initial radiation timeframe. But we're also really interested in working to do some more research to try to understand how those therapies might be combined together, or other immunotherapies might be combined with focused ultrasound in the future. So our hope is to also pretty quickly develop some correlative studies that may go across all of these focused ultrasound studies to help understand if there's some immune activation that might occur that we could harness to kind of think about other combination therapies in the future. So I think there's definitely a lot of work there. We are a part of kind of every consortium at Children's National. So we really, we have, several other studies open or close to opening. We're, participating in the DMG Act study through PNOC and have a number of other kind of studies that are coming down the pike through Connect and some other consortia as well. But I think the REMIND one being one that is unique to our institution, and we have had a number of children with DIPG that have come from across the country and even other countries with interest in that approach. But we are very interested as an institution in thinking about how focused ultrasound and immunotherapy might potentially interact in the future as well.
So can I ask you about the REMIND study? Is it advisable after this ALA sonodynamic therapy, or they go, if you see a patient, what, which clinical trial would you recommend for,
Yeah, that's a great question and a little bit difficult. I do think there are some things that make us think about kind of immunotherapy being a little bit higher risk that are child specific. So obviously some of the worries we've had about immunotherapy in DIPG kind of from our earliest experience when we were trying those treatments in children after their tumor had started to kind of grow or activate again post radiation. And we were worried about seeing kind of inflammation there that led to increased symptoms. So most of the immunotherapy trials really have moved closer to the completion of radiation for that reason, to try to use an immunotherapy approach, which might lead to some inflammation within the tumor area, at least in the tumor environment, or swelling in that area at a time when hopefully the tumor is kind of small and somewhat quiescent after radiation. I think there are certain situations where children are having more trouble kind of coming off their steroids, or things where we may be worried about our ability to train and grow those T cells to adequate numbers that we want to infuse. So there's some situations where we would think one is clearly better than the other. But I think, as a clinician, it's a conversation with different risks and kind of timelines on a study, I think, are a better fit for a different family or a different child. And I always talk with any family about the options that we might have available, and the risks and what we think of in terms of potential benefits for each individual child. We have thought about whether that could be an option to do them both. There are some timelines for each of those studies with regard to time from radiation or diagnosis. For the sonodynamic therapy, that does have to be the first step. The Remind study, that it's not that specific, but it does have to be within 5 months of initial diagnosis. So for like the patients that need the 2 treatments, that timeline's a little bit tight. For some of the children that would just be getting potentially a single sonodynamic therapy approach, that might be a feasible option to think about both.
If you see any growth come back, anything like that, cell activity after the first dose in patient 2 and after, did I understand you would treat again, or?
Yeah, at this point, kind of things are written for that. You mean for if they've only gotten half the treatment?
No,
if in the other subsequent. Mm-hmm. Yeah, I think at this point it's written kind of for that single treatment. Obviously we have interest in thinking about the potentials, down the line for kind of multiple therapies, but at this point that it's written kind of for that single treatment.
Just for one. For those of us that don't have that scientific background, we all hope we would, can you explain a little bit what is happening when the sound waves, the sonodynamic waves, are hitting that ALA in the DIPG cells?
Yeah, so I think that basically, they're then kind of creating these what we call reactive oxygen species, and in a high level, especially because the ALA accumulates, in those tumor cells. So, many of our therapies, chemotherapies, radiation therapy, actually kind of in different ways will generate these reactive oxygen species, which are essentially toxic to the cells and can either result in more direct cell death, or can trigger these pathways that lead to what we call apoptosis, which is more of that programmed cell death.
Okay. And in the GBMs, there wasn't, as I understand, a lot of inflammation or damage to healthy cells around it, which is really encouraging.
Yeah, correct. And it did seem, that, again, the ALA itself is not toxic, to the cells, without kind of being activated by the ultrasound. So again, the hope is that, we're really kind of targeting the tumor, very specifically.
And so the IV delivers the ALA, and then is it within 4 hours? Tell me that timeline again for those that hear the recording a little later.
For the, well, for this study, I can't speak exactly to the IV. I think the timing's about the same, but the Sonalisense team can probably weigh in on that. But for for our study, it will be that they'll receive the infusion, and then between 6 to 9 hours after the infusion is when we'll give the focused ultrasound treatment. And so a long day, and definitely kind of the preparation. There is some preparation time to giving the focused ultrasound. So obviously we have to be giving that to an exact place. So similar to radiation where there's a mask, for this therapy, there is the application of kind of a frame to ensure that we're in the, that the child's head is positioned and it's held still, and that, we're delivering that focused ultrasound kind of exactly where it wants to be, where we want it to be. So that process is expected. Obviously, we'll, I'm sure, get even quicker and quicker at it, but, we, expect that will take an hour or two kind of even before actually giving the ultrasound treatment.
So will the child have sedation during that piece?
Yes. Yeah, I probably should have mentioned that too. Yeah. So the plan is, even though we know some older children can do radiation things without sedation, the plan is to do sedation at this point in these cases.
And I think I missed this at the beginning, but is the infusion through IV or is it a different means?
Through IV.
Through IV. Okay.
It's a pretty quick infusion, but it's more that kind of timing though than relative to the ultrasound treatment.
So in case for your mice models, was it just one dose of the ultrasound plus the ALA, or was it multiple doses that caused the reduction of the tumors?
It depends on the different models, but that one example was multiple treatments.
So in case you see a positive response, would you, you have to open a whole new trial to do multiple applications?
At this point, I think there's always kind of stepwise, fashion. Certainly if we're seeing promising things, I know we'll want to work to do what is needed. But I think I can't speak to exactly how that timeline would look. Sometimes we can amend a trial to add things to it, but obviously we kind of have to get through some of those first safety phases first. So sometimes it does make more sense to kind of open a subsequent trial. Other times there is a way to amend a study once we have some initial aspects or information, but it's always hard to know that, we have kind of the study as planned, and then, sometimes information develops that causes some change to that, but usually we try to write the study and design it in the best way possible at the beginning to get, to do it in the most potential for effectiveness, but also, safety, kind of with something that's this new. But, sometimes over the course of a study, there's something that changes or causes us to change or modify things slightly.
And I think you mentioned this, but what was the age range?
So one of the limitations, so right now the youngest age is 5. One of the limitations just for the ultrasound, the focused ultrasound right now is kind of based on the frame and some other aspects of that. So there are some limitations with regard to like the child's head circumference, like the, kind of measurement around the head, and then also kind of the thickness of the skull. But we think definitely to age 5, as we get more experience, who knows how that may evolve. But for right now, the youngest age is 5.
And I'm sorry if I missed this, but do you guys already have a potential patient that you're going to work with? Or
we have had a couple of patients that have reached out, but we haven't, again, the study is not quite active yet. So we can't kind of fully evaluate anybody until we're sure, that we're ready to go.
And I know it's still, a pretty iffy situation, but are you looking at like weeks, months? how far out do you think you are, or you don't know
I
quite
think
yet?
hopefully weeks. I believe weeks. I don't know.
I agree. I think it's weeks.
Thanks, Anna.
Do you know how many patients you're going to accept into this first round?
Well, again, we have to treat that first child, and then that is really a 2-month process. And then obviously there's always a little wiggle room in terms of making sure we've kind of gotten, through that and gotten and looked at everything to go to the next child. But again, we're going to work to move things through as quickly as we can. Because we do think this is, it's important safety to do it in this way, but we also want to kind of have it available for families that may be interested.
Is this just open for US patients or even like Canada or another country?
Yeah, we often, have patients come from all over the world, honestly, and have a number of international patients in our clinical trials currently. We do have a international office that can help facilitate that sometimes for families from out of the US.
If I'm correct, Children's National has been working on a drug and a form of muscular dystrophy that's a replacement for a steroid. Is it vamorolone? That's close to maybe FDA approval. Is that anything that Children's National would consider for DIPG use?
It's a great question. I think it's not something we've moved to doing yet, but I think there have been a number of studies that in the past where we've tried to kind of think about some steroid alternatives for children with DIPG. I think it's a great question. I appreciate it. And, I think it's something we need to honestly probably should focus on more, but I think have been more focused on, the more therapeutic options. But having just earlier today had a conversation around steroids and one of my patients, my personal patients, it is something we know we greatly need some alternatives that might have that same effectiveness. So it's a great question and will make me go back to that team and think about how we can move that forward. We got to get this open first and then I can work on that.
Yeah. Please let us know if there's anything we can help in that direction, because if it makes the immunotherapies a little easier, it could have a big effect, right? This, because so many times we've got a kid just ready to go into a trial, but they need steroids to keep that swelling down, and we just can't get it reduced enough to start the trial. Is there a steroid restriction with this trial?
No, other than kind of some of our standard, like we want to make sure that we have a period of stability before we're moving into this type of a treatment, but not kind of a specific dose like we do see in some of the immunotherapies.
Excellent. Well, I know.
I'm sorry.
Mom.
Hello, can you hear me?
Yeah.
Oh, so I'm sorry, I forgot the question. So correct me if I just want to understand that.
We lost you.
I think you're muted. Sorry.
Okay, so Remind trial, you said the diagnosis has to be within 5 months, 6 months in order to be eligible for the trial? Is that right?
That study, actually, the infusion of the T cells has to be within 5 months. And so that is a process where we draw blood on 2 different occasions a week apart. And then it's about a 6 to 8 week process to kind of train those T cells. So they're targeted against 3 different tumor-associated antigens. And so kind of that laboratory process of that training the T cells and expanding the T cells into the numbers that we would like to have them to try to then infuse them. That usually takes about 6 to 8 weeks. So so that, you know, there is some wiggle room there in terms of kind of post radiation, but the timing is actually linked more to when those cells are actually given, not to kind of when we start that process.
So is this like CAR T cell therapy?
It's different than CAR T cell therapy. It's kind of a different T cell approach. They're both T cells, but one is looking at the kind of at utilizing this chimeric antigen receptor as opposed to kind of kind of essentially training these T cells to identify particular antigens that we know are commonly presented on tumor cells. So just a little bit different ways of kind of activating or facilitating the T cells to kind of hone to the tumor cells.
So that T cell collection can be done anytime or?
Yeah, we've had some children with DIPG that have actually had their, have even enrolled in the trial before starting radiation. That's not that common, just given the timing of things and the steroids and, other aspects. But so more commonly, we've had families that have come to us kind of in some time period after finishing radiation. There aren't, the limitations around steroids are more for the T cell infusion, because we don't want those cells to be negatively impacted by the steroids that we're giving. But there are some limitations, or we do recognize that if kids are requiring higher doses of steroids, the numbers of their lymphocytes and T cells that are kind of circulating and available to be drawn and then grown and expanded are much lower. So we kind of think about that a little bit in terms of thinking about the timing.
So T cells could be collected even before a patient is enrolled in the trial, is that right?
They are enrolled. There's kind of two phases. There's like what we call the procurement or the collection part of the trial, and then the actual infusion. So there are two separate consents for that. They're linked a little bit, but it is, there are two separate parts to that study.
Okay, thank you.
Well, we wish you all the best with this trial to everyone involved. And we would love to hear how it's going as CureFest rolls around in September, when we all seem to get together and kind of celebrate the wins of the year and look forward to new successes in the following year. But I, for one, just want to thank you and applaud you for being willing to take those shots on the rim, as we say, because it's going to take something like this, different than what we've tried in the past, to make it a difference, I believe. And that takes courage. And I know your days aren't easy, Dr. Kilburn, and we just applaud you for being willing to step out in faith of what you've seen in Dr. Nazarian's lab and in the GBM world and give it a try. So.
Thank you so much. Thank you so much for doing this, really.
Thank you. Thanks to all of you. It really does, as they say, takes a village, and I am always inspired and re-inspired by getting to kind of meet with the families and that have been touched by this disease. I know it's a group that no one wants to join, but it's an inspiring and powerful and amazing group of people that really pushes us to keep working and to keep really trying to find these goals. I really would love to retire, but until we get that cure, we'll be working for a long time. So I'm happy to retire early. So we just need to keep working harder and faster.
Yes, no, and I'd like to thank you too. And yeah, exactly what Lisa said. So thank you so much. We're so honored that you're here. We can't thank you enough for your time. And I completely agree with you. And I think Lisa would agree too. Our whole goal is to drive ourselves out of business. So yeah, so, and thank you for allowing us to forge through and trying to accomplish that goal, and your time and your effort and everything you do to support us. We can't thank you enough as like a community, as a mom from a DIPG child. So thank you so much.
Thank you.